Hello, class. Welcome to the second half of Pathophysiology of the lungs. Now, the lungs, a lot of this is pretty complex. There's a lot of subtleties to it. The lungs are really, really delicate organs. So that respiratory membrane and the hundreds of millions of alveoli, if that gets overly thickened, if the blood pressure is off, we're going to talk about neoplasms, lung cancers, and diagnosing them too is difficult. I mean, you have general dyspnea, tachypnea, things like that, breathing issues, but then diagnosing what the issue is. And it's often idiopathic too, so that adds to the mix. But we'll go ahead and talk about the rest of the major lung issues now. All right. So we're going to pick up with obstructive pulmonary diseases. So these are things obviously obstructing the ability to bring air in, but to bring air out especially. So if that gets blocked off for some reason, the air behind it gets trapped, the mucus gets trapped, it can't be released, so bacteria can grow in that. And yeah, and if you're not be able to exchange this air, you're going to have carbon dioxide levels go up, not get enough oxygen, and so going to cause big problems. You know, maybe immediately noticeable in their oxygen hungry organs like your brains and your kidneys. Maybe you turn cyanotic. Definitely your breathing center will pick up the pace and try to do something about it. More red blood cells will be produced to try to help that oxygenation. So symptoms you're going to see in all these, the coughing, the wheezing, you're going to have difficulty breathing, rapid breathing. We'll talk about asthma first. Very, very, very interesting asthma. And some of you probably some of you out there have it. And what it is it's going to be a spasm of the bronchi. So your air tubes are going to be constricted. Because smooth muscle will constrict it. You'll often have overproduction of mucus, both of those feeding into narrowed airways and difficulty breathing, particularly exhaling. And the key with asthma is that it's episodic. You're perfectly normal, and then you have an asthma attack, and then you go back to normal again. I mean, with continued asthma attacks, you can cause damage, thickening of the bronchi, but the main characteristic is that it's reversible. And so when you're having an asthma attack, I've never had one, but it can cause anxiety when you're not able to breathe. And asthma, it's a killer too. It can be a killer, so very serious asthma. So the diagnosis of asthma is this difficulty breathing. You can do spirometry and see, oh my gosh, your FEV1 over FVC is really small percentage, not good at all. But the difference between this and some of chronic bronchitis is that we can give you bronchodilators, an inhaler, albuterol, something like that, and you're able to breathe again. Yeah. So like angina with myocardial infarction, it can get better. Asthma gets better. Some of these chronic pulmonary diseases, you don't get better. You don't have any relief from that feeling you have when you have asthma. So the pathophysiology, this is, again, there's a lot of unknown here. You guys have been reading up on asthma. There's a lot we just don't know. Some of it's genetic, definitely. If you have identical twin, you're about 20, if one has, you're about 25% that twin has it. And you guys maybe know in your family if asthma runs in it. But there's some kind of irritant, some kind of allergen that causes this overreaction. And so the bronchi become oversensitive. And the smooth muscle constricts, you're making way too much mucus. And this is in a situation where it shouldn't happen, it has no benefit to you. And why it does this is an interesting question. But some of these triggers, you're familiar with, would be pollen, in the air, cockroach droppings quite a bit, chemicals. Some people have cold or smoke or exercise induced asthma, Pet dander is a big one. And then interesting, aspirin and definitely like benzene and chemicals too can bring about asthma in people. So indeed, when you look at this disease, and we'll talk interestingly how it's increasing in the population. So genetic, there's a genetic component, and then environmental, and yeah, both of these factor in whether you're going to show asthma or not. So indeed, when you look at hypersensitivity reaction, it's chronic inflammation, reversible, and this hypersensitivity, you see something extrinsic. Atopic means that you have some genetic predisposition to be overreacting to a particular substance, and it causes a reaction somewhere elsewhere in your body. It's not like just where it touches, it's going to cause this overall reaction. So people have that. And then this intrinsic idea, not something from the outside, is this stress and cold and exercise that also causes it. So you can see there's complex, and there's a couple things going on. What do we do for asthma? Well, you try to avoid the allergen. If it's ragweed, it's almost impossible if you live, a lot of parts of the country. In the spring, it's just going to be there. But yeah, and you can do allergen tests to see what's. They put a little bit of it into your skin to see if you react to it. But mainly, bronchodilators is the key. You want to make that smooth muscle relax to end that asthma episode, and tell the mucus glands, you're overreacting. We don't need all this mucus. And if it's very serious, you can look at other anti-inflammatory drugs, even steroids. But being on steroids has other ill effects. I don't know if you guys remember that, but it's immunosuppressant, and so you don't really want long-term steroid use if you're going to avoid it. And a real serious one is brittle asthma, is where you have serious, you're unable to breathe, and it can cause death. So status asthmaticus is something that if you got to get to the hospital, they need to make sure you can breathe. And you can look at, when you look at asthma-related deaths, you can see asthma kills. It's not just an annoyance. You see along the older age group, in particular, more likely to have a fatal episode. But asthma in general happens, if you're going to have it, comes about early in life, when you're a child and adolescent. And asthma can get better, as you get older. It's very common for that to happen too. So looking at the world, it's one of these diseases. It's kind of interesting when you look at the epidemiology, the distribution of it. What you see here is that places with a lot of asthma, you're looking at Portugal and UK and Iceland and Sweden and Norway and Australia, and then even US. And what you're seeing is the places without much asthma are a lot of Asia, China, and India, places in Africa, Mexico. So we often see this disease coming about in countries that are have a higher GDP, that are more, I don't want to use the term advanced countries because that's ridiculous, but they have richer countries. And so maybe it's involved with something to do with the environment, the idea of exposure to things you find in these countries as opposed to places that we have less industrialization. And it's going up in the world. This is just showing the US. This is 1985 to 96. Take a look at that. And the blue line up top is the young, less than 18. So it has the highest incident when you're younger. Increasing. Why is it increasing? Why is something like asthma increasing? Well, one idea is this hygiene hypothesis that I'm sure many of you are aware of. And does this explain it? I mean, back when I was a kid, we just ate dirt, played in dirt. There wasn't any of that. I got chicken pox and all this stuff when I was a kid. Now we have antibiotic toys, antibiotic soap. We wash, everything and spray everything with bleach. And it's possible an unintended result of that is that we're making our children grow up to be more hypersensitive and have more things like asthma and allergies, a peanut allergy, things like that have come about. They're increasing in our industrialized world. Maybe it's too clean. Well, what evidence is that? Well, you find out that kids in homes with pets have a lower incidence of asthma. And then you look, if you grow on farms, larger families, put them in daycare. So if you're a single kid, homeschooled and isolated and kept really clean, you're more likely to get asthma. The stats are there. This again is still a hypothesis because it's a correlation, right? And antibiotic use too. We use a lot more as a kid than we used to. And even delivery, a live birth, you go through the mom's vaginal canal and you pick up bacteria there. But a C-section babies are more likely to get asthma. Fascinating, huh? And there's even a correlation, a study out there showing the more affluent, the richer you are, the more likely you are to have asthma. So maybe if you're less well off, you're exposed to more bacteria and viruses. So anyway, throwing that out there for a lot of these, not only for asthma, but for some other things, this idea that we're too coddled and we're not exposed to enough, so our immune systems overreact. All right, here's the biggie. This is the big killer in the world. I mean, after heart issues and cancer, COPD. This is chronic, so long-term, non-reversible, obstructive pulmonary disease. And when you see COPD, there's two diseases that go together. Almost no one has one without the other. And it's chronic bronchitis, where your bronchi are just enlarged, in the smooth muscle can hypertrophy, and there's too much mucus production. So you have this cough with sputum for, there's a technical definition, at least 3 months, 2 years in a row, it's just to put you in that category. Yeah, and the other thing that goes with it is emphysema. And emphysema is where you take the nice, delicate alveoli structure and they kind of coalesce into these big bubbles, which have a lot less surface area. So it's a lot worse for gas exchange, this emphysema. Yeah, so you can see chronic difficulty breathing with coughing always and sputum. And both of these, smoking the major cause. In some cases, you cannot be a smoker and get these in percentage-wise. There's a few small percentage, but it's a disease of chronic smoking. So this bronchitis, this picture shows some enlarged mucus glands. So if this always happens, you've got this bronchitis, you're going to have metaplasia, you're going to change in the tissue. It's going to just be permanently thickened, permanently narrowed. And because of the blockages, you're going to have more respiratory infections because that mucus can't get out of there. So chronic bronchitis, what can you do? You can just really work on the symptoms, right? Bronchodilators to try to relax that muscle, antibiotics to try to fight off the infections, and steroids to try to lower the inflammatory response and tell it to calm down. And emphysema, this is a nice picture. And I pulled out cadaver lungs that have this bullous edema, these big, like balloons, bubbles, pretty gross, like on the outside of the lung, especially in the top, the outside of the lung. And those things, they can rupture and send air in the pleural cavity. But the main thing is they're dead air in terms of gas exchange. It's just dead air that is going to, your lungs they're called hyperinflated. And so there's air in it, but it's useless air because it's not being exchanged. And it's in this big cavities instead of this delicate structure. Yep, so your lungs become less elastic, and like that analogy I showed you, the balloon versus a paper bag. You don't have the healthy elastic in the alveolar walls to push the air back out. And there's no fixing it. You can't go from emphysema and take some miracle drug and put your lung back in good shape. So if it eventually destroys the lung, you die or you get a lung transplant. Beautiful histological section. Here you're seeing it's more normal lung. And then here you're seeing an area of emphysema where instead of having individual alveoli, all these alveoli have been destroyed and it's just one big space. So you see this overlap? I like it. So emphysema, chronic bronchitis, you can be one way or the other, but COPD, it's going to be these things working together. So problems with ventilation, it's true. And what happens if you have this chronic lung problem is that you have a chronic hypercapnia. You're hypercapnic. Oh my God, you have high levels of CO2. I'm sure I can say that. That's an issue because normally when CO2 gets high, it's going to cause you to your breathing to increase. But your body readjusts because you're chronically have this high CO2 levels. And at this point, your oxygen, as I told you in an earlier lecture, that's kind of a backup, your oxygen levels. That kicks in. If you're that low in oxygen, that kicks in. And so you're really living on the edge where your body's doing everything it can to get that oxygen. And by being careful, that means if you do give supplemental oxygen, you can actually stop the breathing. You need to give CO2 with the oxygen to make sure that they're still breathing. So this is looking at an X-ray of a person, and you guys aren't experts. I'm not personally an expert in reading these X-rays either, but I do recognize that these lungs are huge. They're hyperinflated. The diaphragm has been pushed down to either side, and because you've got all this dead air, and the lungs are large, but they don't empty, and it's difficult to breathe. And these patients will be using their chest muscles, their neck muscles, and to try to move air in this rapid breathing. It's also, notice how dark it is here, especially there. It's really dark because instead of having lung tissue, you've got big air pockets, and so air makes it lighter. So the lungs should look darker where the lungs are because they're airy, but this shows like a lot of air. So in particular, it shows that this is way too airy. Yeah, so these two things, and in the business, they talk about these two types of patients as being pink puffers and blue bloaters. Now, I don't work in a hospital. I've never used these terms before, but I've read up on it, and Lindsay has told me this too. But they have different looks about them, and depending on what end of the spectrum you are, more as the emphysema or the chronic bronchitis, the problem. But chronic bronchitis, you got the severe hypoxia, so you're blue. You're cyanotic. You can't be cyanotic. You can have lots of pulmonary infections because you keep blocking off the bronchi, and that mucus is going to just be perfect for bacteria. Emphysema, you see this barrel chest. You see, like I showed you, that hyperinflated lung, this big chest. And they're breathing, they're really moving their chest muscles all the time. And so they'll be thin because you take so much energy to breathe. Normally you and I just use our diaphragm, and it's a very simple process to breathe. Here they're using all these muscles to try to ventilate those lungs. So another look at it, yeah, you can see, and again, look at the size of the lungs in emphysema. They're just hyperinflated. So then the diaphragms don't have much to work with. It's been pushed down. It should be dome-shaped, right? And be able to depress. But in this case, no. So your chest muscles, your pecs, your scalenes in your neck are helping to move that chest. Indeed, and you'll see some differences there. You can look through them yourself, but yeah, typical looking patients, you can look at them and say, okay, well, what's going on inside? So what do you do about COPD? It's progressive, it's chronic. So honestly, you're not going to get better. Well, you're not going to be cured. Okay, what you can do is make your life, try to make it easier. If you're still smoking, I mean, I bet you'll have patients that, take the oxygen away to smoke. I've talked a lot about how horrible and addictive it is. But yeah, you want to use the bronchodilators and steroids as much as you can to try to open things up. Give oxygen. You might see someone carrying an oxygen tank with a cannula on their nose. And there's going to be a lot of antibiotics involved. because you're going to have trapped mucus that's going to have bacteria. And there are some surgical interventions. Sometimes emphysema can be helped if you go and resect or remove a lobe of the lung. If you remove the part that's really just dead and like that, the rest of everything works better. So some lung surgery can be done, and lung transplants are possible as well. Get whole new lungs. All right, so COPD. Talked quite a bit about it. It's going to be just a common disease in our smoking society. All right, let's talk about some diseases. Interstitial diseases means we're no longer talking about in the alveoli. We're talking about the alveolar walls. And just to give you a big picture, what happens is that those alveolar walls become an inflammation. Neutrophils come in. They're putting out proteases and enzymes that destroy the bad guys, but they also destroy the alveolar walls. And you get inflammation and destruction, and it turns into fibrous tissue. So it becomes less flexible, less elastic. And it's going to be a restrictive type of lung injury instead of airflow problem. It's going to be, you don't have that elasticity anymore. And so it's not going to snap back and exhale. Common symptoms, of course, dyspnea, difficulty breathing, tachypnea, rapid breathing. And if there's a real issue, you turn cyanotic or blue because you can't oxygenate your blood. And again, going on with this, pulmonary hypertension. So if the lungs are all, interstitial layer is where the vessels are, the capillaries. And so if they get influenced, it's going to be just harder to push that blood through the lungs. So the pressure is going to go up. Cor pulmonale, your right side of your heart is going to enlarge, trying to push that blood through. And then infections, of course, because things are stagnant. The mucus is not being brought up and cleaned. And some real bad things, of course, pulmonary edema, water getting into the lungs with that pressure, and the alveoli can be irreversibly damaged. So there's pulmonary edema. We've already talked about it, edema. But it's not really a lung issue. It's going to be a heart issue, really. It's increased pressure, pulmonary hypertension, is going to cause more fluid to leave the capillaries and get sucked back in, right? Could be a real low osmotic pressure in the capillaries too. If you didn't have many proteins, it would also cause edema. But mainly, we're talking about backup in the lungs. Let's say the left side of your heart is failing; it can't pump the blood away. Blood is going to back up in the lungs, and it's going to be higher pressure. More water is going to leave. Yep, and so fluid's going to leak into the alveoli, leak into the interstitium tissue, and you're going to hear that the rails, as you breathe in and out, you can feel, you can listen to the tapping and hear how it gets duller. So this fluid feeling is like you're drowning. You're drowning in your own fluid. Yeah, it can happen quickly after smoke inhalation in a fire. All right, ARDS. If you guys work in a hospital, this is a big killer. If you get ARDS, it's about 50-50 survival rate. This happens to people usually that are in the intensive care unit. If they're not, they're going to be if you have ARDS. What happens is that you're just going to have this big injury to the alveoli of your lungs. And so you see the picture below. Here's normal. Look at that blood vessel. You see the alveoli. The wall is wicked thin, right? There's no fluid in there. On this side, and it develops just like that respiratory distress in the newborn. You're going to have all this inflammation and immune response, and it's going to precipitate out all these chemicals that are in there, the pus, the white blood cells, everything is going to come out as this kind of a hyaline looking membrane. Which is going to thicken the alveolar wall, and then it's going to be damaged, and you're not going to have that diffusion of gases. So this happens usually both lungs, all over. ARDS. So ARDS is acute respiratory distress syndrome. So people that you need to get on a ventilator. It's really, really critical because their lungs all over the alveoli are being damaged, and so they need oxygen. Some conditions, looking at it here, you can see overwhelming infections. Indeed, sometimes you see traumatic head injuries. What happens here often is that they don't have that defensive ability to prevent aspirating foreign substances or gastric throwing up and swallowing, all these things. And so you often see with head injuries, you see lung involvement in that way. Indeed, aspirating things, yeah. Remember what iatrogenic means? Caused by the medical procedure. So indeed, contrast material for doing a MRI or something like that could cause this, or transfusion reactions, drugs, yeah. So ARDS, you can see here's a person, wow, I mean, their whole lungs are being affected by this. And so you need to go in and see what is causing this to see if that can be stopped. And then a lot of talk about mechanical ventilators now with COVID, get them on oxygen and ventilation to try to allow them to get through this. All right, look at this, chronic diffuse interstitial disease, right? So it's diffuse and it is chronic and it's a disease of the interstitium of the lung. And here we're going to see, I'm going to show you some examples of these things where the interstitial tissue is irritated over a long period of time and becomes fibrotic. So your lung is just slowly from this nice, soft, like Nerf football feeling thing. You take out one of these out of a cadaver and it's hard and it's not, you know, it's fibrous. And your lung's not going to move like it should. It's not going to fill with air, and you're going to have all kinds of issues. So how do you diagnose this? Yeah, definitely trouble breathing, rapid breathing, but you don't see the obstruction, something in the interstitial tissue. Yeah, and you'll often see when you look at the X-ray, you'll see all of these, they often come as streaks and such, and little all throughout there, you'll see called ground glass opacities. So as you learn to read X-rays, this is something that is indicative. I took a nice picture of it here. This is a beautiful, look at this view to show you a couple different radiological techniques, right? You're seeing the X-ray on this side and then a CT scan of the same lungs. It's just gorgeous. Look at the two of them. Can you line them up? You can see the problem. So there's two ways of looking at it. That's beautiful, yeah. I mean, it's horrible for the patient. This is very bad, but the imaging, to be able to line those up and see what it looks like in two different techniques is nice. Yeah. So these opacities, the white in there is going to be thickening of that the interstitial tissue, not the inside the alveoli, but the walls of the alveoli. And there's going to be many causes. And actually, when it comes down to it, your book talks a little bit about there's a point where it's not critical to identify the culprit as much as figure out, how quickly can we slow this down? Because in the end, they all turn out the same. So it's, if there's going to be like in some pneumonias, if you can figure out the bacteria as early as possible, that's awesome because we know antibiotics specifically for that. In this case, you have this fibrosis forming, and if we don't have options, different paths to take, it doesn't really matter the cause. So that's what I'm trying to get at here, is that this honeycomb lung, difficulty breathing, all these things are going to be consequences of many different interstitial diseases here. And lots of infections, abscesses, All right, so looking at this, pneumoconiosis, got it. That is going to be when you take in particulate matter, and normally your lungs, the macrophages they do a good job. They can eat, get rid of it, But if you have too much, then that particulate matter is going to cause your alveoli to be inflamed. So you're going to have neutrophils come in. You're going to have that inflammatory response, which you don't want. And eventually, this is chronic. It builds up. you start making scarring and fibrotic tissue. So your lung becomes less flexible. And you see this, coal miners, imagine working in places industrially where there's lots of dust. If you do a drywaller and you don't wear a mask, things like that, you're constantly assaulting. And the particles, your nose does some work, a mask does some work in filtering it, going down, even the trachea, you've got mucus, the elevator, escalator, elevator, whatever. But particles of a certain size can travel down to the alveoli where they need to be cleaned up. And you can overwhelm your macrophages. Yeah, well, a famous one, anthracosis, is when you have carbon accumulating, and the coal miner is a good example. What's interesting is carbon is not a real bad irritant. So you see some people, and I've cut open lungs and I've seen just black or bluish black streaks and bright black purple lymph nodes, and these people didn't die of lung issues. So you can take care of a lot of carbon and sequester it, and you can see this, look at this lung with all that black in it, and no problem for some people. Other people, it turns into granulomas and issues. Anyway, but if you live in highly polluted areas, you don't have to be a coal miner, smoke tons of cigarettes, work in somewhere with a lot of dirty air, it's going to build up in your lungs, anthracosis. And it can be dramatic how black the lungs look, black lung disease. And a couple other things, silica and asbestos are a couple minerals that really can cause havoc if those small particles get into your lung. So silicosis, often I show that when people work with stone or concrete that has silica in it, without proper, ventilation, even with, depending on your mask, if you work for decades, you're going to inhale some. And eventually that causes scar tissue in your lungs. And asbestos, of course, is famous, right? When I grew up, it was, we use asbestos for insulating. It's fireproof, it's great. But now you all know, asbestos is bad, because not only is it an irritant, it's going to cause this fibrosis, but it's a known carcinogen. It causes lung cancer and mesothelioma. You may hear that late night commercials, lawyers, do you have mesothelioma? That's a cancer of your pleural membranes. So yes, these two things, asbestos and silica, your lungs overreact to that badly. Yeah, cool, another cadaver view. Look at that dark chocolate colored stuff right there. It's gonna be silica. I went in there and carbon. All right, now there's something, here's an allergic kind of reaction, a hypersensitivity reaction that builds. It turns out, let's say you work there's lots of hay, you work in a barn, or you're a pigeon breeder, and there's all, this dust is there every day. You get hypersensitive to it. You start getting a reaction to it. And eventually this fibrosis will occur, and it will ruin your lung function with time. So this is a fibrosis that is a hypersensitivity where you're exposed to it and you get more and more sensitive to it. You can see pigeon fancier's lungs. People get pigeon dropping. So it's usually some kind of organic matter. Oh, some examples here. Cheese casings, grapes, peat moss. Depends. Usually it's an occupational type thing. You're around it day after day. Maple bark, maybe working a sawmill kind of thing, or definitely grains, the grain dust gets in there, and you develop an allergy to it, and you have a hypersensitivity to it. Here's a weird disease here, sarcoidosis. And sarcoidosis, right, is what happens is you get these little granulomas, and we're talking about now because it most likely found in the lung and lymph nodes. You find these granulomas, but also in your skin and in your joints and other places too. And so it develops. We're not unknown. We don't know why, but you have these little granulations that form, and they can kill you by taking over your lung and getting it in bad places. So it's really a mystery. They can come and go. They'll put you on steroids to try to shrink them. But sarcoidosis is another a way to get fibroids in your lungs. And this shows one. You can this is lung tissue. It doesn't look like good lung tissue, but you can see here the arrow is on one of those granulations, granulomas, and it has, remember we talked about these with the macrophages in the center, and it's kind of encapsulates it. And you see it, you can see here the lymph nodes in this hilar region of the lung where it comes in. And it has a distribution, southern US, Black people more, women more, young adults get it. So we think it's some, look at this, immunological predisposition and some unknown antigen in the environment. And when you look at something like a geographic difference or gradients, you often look for environments. I mean, it's unlikely there isn't the genetics, the genes aren't flowing between there. It's probably something that has to do with something in the environment. But we don't know. We don't know. All right, here's a mouthful for you, but you guys know all these words. So pulmonary fibrosis means fibrous. Your lungs become fibrous. Diffuse, it's not concentrated, it's all over. And then idiopathic, you don't know the cause. So this is fibrosis that happens in your lungs. We don't know why. And in this case, it's throughout your lungs. It often kind of starts on the outside and moves to the inside. And look at this picture here. We're looking at fibroids throughout the lungs. So this is eventually, if this is going to spread like this and we don't know how to stop it, it's fatal. It's going to take over the entire lungs. You can see the course is unpredictable, but you take an image and you really see that. And just to point out again, what's the problem with your alveolar walls getting thick? I mean, you know pneumonia, if you got bacteria and fluid in the alveoli, it's going to prevent oxygen. But you can see as those walls get thicker and thicker, they become less and less useful for diffusion of gases. All right, so vascular conditions, and we talked about this really embolisms when we did a circulatory system. But just to remind you again, a PE, a pulmonary embolism, big killer. Usually you have a clot in your lower leg or in your pelvis. It goes up your inferior vena cava, goes into your right atrium, makes it into the right ventricle, makes it through your pulmonary trunk, out your pulmonary arteries. Then things start getting small. And those little pulmonary arteries, eventually it's going to hit a small one, usually where there's kind of a bifurcation, and it's going to get stuck. And it's going to block blood flow to that part. The blood can't return to the heart. The pulmonary embolism is a fatal condition if it's large enough. So small, it depends. Small ones just affect the periphery, you're going to be okay. One even in a medium size or definitely in a large size vessel is going to cause immediate symptoms, chest pain and death. It causes death often. This is a big killer. So what makes you more likely to get a PE? If you are immobile, remember when blood is static, when it doesn't move, those clotting factors build up. So especially people that are in hospital beds after a surgery. Indeed, if you break a bone, you could have a fat embolism that could come out. If you have a coagulopathy, where you have a coagulating problem, where you make clots more often, endocarditis, something like that, or a heart attack where you're making clots in your heart, they're going to travel. And obesity tends to show more clots, and when you're pregnant, you have more clots too. But as you can see, imagine a clot forming behind your knee. It gets loose, and it's going to block off the blood flow in your lungs. So, pulmonary embolism. Pulmonary hypertension is high blood pressure in your pulmonary circuit. And here's your poor right ventricle, right, trying to get the blood out to your lungs. And there's so much resistance that you can see here, it's even the blood is regurgitating back into the right atrium. But this is chronic. Your right ventricles, the walls are going to hypertrophy and get stronger and stronger try to push that blood through. I guess we define it as the pressure in the lungs being 1/4 of the systemic circulation. It should be less than that because there's not usually much resistance in the lungs. What causes this? I mean, atherosclerosis. You're going to see a hardening, narrowing of the arteries. Yep. And again, COPD, PE. You could have diseases that attack the blood vessels in the lungs that won't cause the vessels to be constricted. So, a lot of things. Now we know in the heart, if you have an embolism, it's gonna block off blood flow, and you're gonna get a myocardial infarction. An infarct is when that tissue dies because of lack of blood and oxygen. A pulmonary infarct is rare. It's because you've got collateral circulation. You've got a lot of blood flow in the lung, not only from the pulmonary arteries, but then you have bronchial arteries that come off the aorta that serve the lung. So it's unlikely you're going to have an isolated part of the lung that can infarct, but it can happen. And this picture here shows a part of the lung dead because it has no blood flow. So it can happen. You can see that pulmonary embolism in a medium-sized artery. And if it's on the pleural surface, that infarct causes pain and breathing. So yeah, you can have a pulmonary infarct like a coronary infarct, but it's a lot less likely. All right, and our last topic for this lecture is really the lung cancers. And lung cancer is the leading cause of death in cancer. It's not the most common cancer, but it's like I mentioned, it's very deadly. And we'll see also a lot of other cancers metastasize to the lungs because all the blood comes from your body, from your liver, and it's liver cancer, your colon, goes through to your heart, goes out to your lungs. And so there's a lot of vascularization. So a lung is a place where blood travels all the time, and so it's a good place for a metastasis to get caught and to grow. All right. Most lung cancers that arise in the lungs are from the epithelium of the bronchi. Clearly, if you smoke, you can expose those cells to lots of mutations, right? And when you look at the world of cancers, you guys have heard these before, small cell carcinoma or non-small cell. The book explains why we don't call it small cell and large cell. It'd make more sense, but because it'd be a little confusing. So small cell and non-small cell is the terminology that we use. And you want to hear non-small cell. It's a little better prognosis. It's more common. Small cell, you can see it's not easy just to cut it out and has a worse prognosis. So all kinds of different variants of this, right? If you're an oncologist, you know all these different types of small cell and non-small cell cancers, right? But the symptoms, it's hard to really screen for lung cancer because the tumors start so small and no one gets chest x-rays unless there's a reason, right? So, usually they gotta be a certain size, you start showing symptoms, and by then it's already grown and possibly moved along. So you see the issue? Yeah. But the symptoms could be the tumor itself growing. And there's one case that's interesting. You guys remember your A&P? Actually, I didn't even get into this in detail in A&P. Your vagus nerve comes down, and then there's a branch called the recurrent laryngeal that comes off it, loops around the heart, and then comes back up to your vocal cords. And sometimes cancers will impede that nerve, and you'll see this change in your voice, your hoarseness, and it's from down here where that nerve was next to the lungs. I just wanted kind of example. Or obstructive, if the cancer actually grows into the bronchi, and then you're going to have you're going to have obstructive diseases. You're not going to be able to breathe as well, blockage, so you have more pneumonia, and then maybe they do that chest X-ray, and then they can find, we see a mass. And if they see a mass, an opacity in the X-ray, you can't tell it's cancer right by that definitively, or certainly what kind. But then you want to do, I'm showing a lung biopsy here. So they'll get you under some kind of camera, CT or X or something like that, and they'll guide the needle, and so they can take a biopsy of it to look at it. And they may found that it was a bronchial squamous cell type that came right from the lungs, or they may say, oh, this was liver cancer that spread there, right? So I'll show you a couple kinds here. You can take a look, a couple kinds of cancer here. You can see here's squamous cell. And if you look at it, I can tell you, but these are actually like keratin, like from your skin. You know, so you can see that, and you see some cells abnormally dividing. But that's kind of a look. I'm not going to ask you guys to recognize it, but just to give you a view here, squamous cell carcinoma. The other one would be an edemocarcinoma coming from glands. And here you can see a whole bunch of glands forming. It's in your lung. You know, it's you got cuboidal cells in the lung for. So, I mean, okay, you have some in the medium-sized bronchi, but this is a bunch of glands in the lung that does not belong. So it came from somewhere else. It's starting to grow there. What about these cancers? How do you stage them? I'll show you a chart that you do not need to memorize at all, but you should know you stage it like we stage some other cancers by how big is it? You know, is it 5 centimeters? Is it less? Is it more? And then has it spread? Has it metastasized? You can look for nearby lymph nodes, usually hilum or under their thorax or along the blood vessels. See if it's spread, or my God, spread to brain or bone as well. Yeah, and when you hear lymphatic or hematogenous, means of course by lymph or by blood. Yeah, take a look, and you can see the survival rate here on this column here too, right? Yeah. So if the tumor, they catch it small, you know, less than an inch, about an inch in size, 50% 5-year survival. You guys think that's good or bad? Can go either way with that one. And then down to a 5% 5-year survival if the tumor is already between 5 and 7 centimeters and was larger than 5. It's metastasized to lymph nodes. Yeah. Right. Yeah. And by the time, if you find cancer that is in the brain and in the bones and in the lung, your prognosis can be very, very short. This shows, it's a cat. This shows an X-ray, so you guys can get a. This is a particularly nice view of looking at this is a carcinoma here. So this, originated, it took hold in the lung and it's growing there. Small cell carcinoma, not good. You can take a look at it. You can see mitosis looks really weird right there, doesn't it? Yeah. Actually, that looks like a nucleus there. It's probably cells to be. So cells are dividing way too rapidly. All right, screening for lung cancer. Now that I've scared you enough with the, you know, how difficult it is to diagnose, how difficult it is to screen for, and how bad the prognosis is, what's the good news? Well, I don't have a lot of good news here, because screening is notoriously difficult. To take a look at reading these X-rays, you can imagine how difficult it is. You're just looking at them. I mean, I show you some of the most advanced cases here, so you're clear to see that. But to pick out a small white dot, you know, in that whole field of the lung, so by the time you find it is often too late. And you can't just give CTs and X-rays to everyone, even if they're smokers, because it's expensive and it's dangerous, you know, that radiation to give them. So you need to have a good reason. Unfortunately, it could be coughing up blood. It could be, that's the first sign and you're already at stage 3 or something like that. All right. And so you should know what pack years are. That's how they determine your chances of getting lung cancer. And so, yeah, I mean, you can see 1 pack year is when you have a 1 pack per day. Well, a pack year is how many packs. Yeah, so you multiply the number of packs. So someone that smoked 1 pack for 30 years, we have the same pack years as someone that smoked 2 packs for 15 years. So it's a way to measure how many cigarettes. My God, 7,000 with just 1 pack a day. It's a lot of smoke. Well, what do we do? What do we do with this cancer? What are the, you guys know, because we talked about cancers. Indeed, chemotherapy, radiation therapy. It can be, your best bet is if you catch the tumor early and you you can just excise it, remove it, you remove all those cells, you're cured. You're cured. And now, of course, they come up with some of these immunotherapies and targeted therapies. And this is if when they do a biopsy, they will genetically test those cells and they'll see exactly what kind it is. And then we've got some real expensive drugs that just act on the metabolism of those particular cells to really target them. But we don't have a lot of these, and hopefully we get better and better at it. And the lung is a place that a lot of other cancers will metastasize to. As I said, there's a lot of blood flow in your lung. And so any little embolism filled with cancerous cells can find its way there and take hold. Breast, prostate, colon, yeah. And sarcomas, place where they metastasize, cancers of connective tissue. Wow. Again, beautiful view of X-ray, CT scan. You can see, you guys notice opacities there. All right, and finally, what happens when this organ fails? Well, you can't survive without it, right? The lungs, you get to the point, what happens is as the lungs, they get to a point where they're not adequate for gas exchange. And you don't have high enough oxygen levels. You're going to be cyanotic. No matter how much you increase your breathing rates or depth, you cannot get enough oxygen. Carbon dioxide builds up, you're acidotic, and you would die, of course. I mean, they'll give you supplemental oxygen, ventilators, all these things, but it's pretty straightforward why you die if this organ fails. So, this is kind of just a review looking at that. So diseases of the alveolar wall, that ARDS, that you get edema of the wall or fibrosis, that takes over, your lungs can't function. The chest wall itself, you can have an inability to breathe because your vertebrae actually get so much of that kyphosis, right? That bending, ribs, you can have rib problems. Really bad scoliosis will collapse one lung. One lung will be small, one lung will be bad if it's untreated. The muscles, your breathing muscles could be affected, polio or by other neurological problems, so you can't ventilate. Atelectasis is if you have a collapsed lung. And one is going to be, you can have one, so you have your diaphragm, like it's called, you have a hemi breathing like this, and if both of them collapse, they just don't, you've got minutes, to live. You need to reinflate those lungs. And diseases in the alveolar spaces, so things in the alveolar spaces like, well, obviously pneumonia and edema that fills up the spaces. And also they talk about here also about things like drowning and strangulation, things that are also going to cause your lungs to fail if it clearly can't feel your lungs are there with those things. Yeah. And then trauma, some head trauma if you damage the respiratory centers, or OD on opiates and various drugs that are going to depress your breathing, right? And it's a little dangerous for people that have depressed breathing to give them some opiates because it further depresses the breathing, and a lot of drug overdoses and stuff because of this. All right, so if you have lung failure, you can have sudden death. Pulmonary embolism, talked about that. Both your lungs collapse, you've got minutes to live, right? So obviously sudden death, you can have severe illness that comes out leading to death. Thinking about COVID now, I'm thinking about some other diseases that very rapidly come on. And then if you have a long, like COPD, a long chronic disease or fibric disease that's destroying your lungs, yeah, over time, your lung function gets worse and worse and worse, and your quality of life gets worse and worse and worse. And honestly, I think one of the worst ways to die really is to have COPD and you have lung issues that you just are working so hard to breathe, and you have a feeling of not being able to breathe. remember having pneumonia and like feeling anxious and worried that, you know, with one breath, you know, I would not be able to breathe at one point. And if you're alone, that that's it, right? So this this difficulty breathing if you destroy your lungs is just really kind of a horrific thing to think about, is to have to fight so hard to breathe always, you know, without. It's for those of you with asthma know that anxiety, that fear, but you know, there's another side to it. With these chronic diseases, there's no really getting better, right? Anyway, with the chronic lung function, you guys know now some of the things that go along with that. The edema, if your lungs, there's hypertension, and the heart has difficulty getting the blood through it, you're going to have a higher pressure. Your liver can get bigger, your spleen, your lower legs get bigger. Just, it's a characteristic of heart failure and lung issues too. And if it is a lung cancer death, I talked about what causes death with cancers. So usually it's going to be some kind of infection or cachexia, where there's a wasting disease for various reasons. All right, we ended up talking about lung cancer, the very deadliest, well, I say very deadliest, but it's a major killer. There's some other cancers, pancreatic cancer, some others that are also really bad, but lung cancer is one of them. And all right, we are done 2 lectures to cover the lungs. So again, it's important, obviously, and this is breathing in today's, COVID world where it affects the lungs. It's important you guys really get a good background of some lung issues. All right.